Hello, my name is Dr. T1 S. Raja. Today I will discuss about ectopic pregnancy. What is ectopic pregnancy? What is its definition? Ectopic pregnancy is the implantation of the embryo outside the uterus. So, the definition. Ectopic pregnancy is the implantation of the embryo It is the implantation of the embryo outside the uterus, outside the uterus. Okay, so that is the definition of ectopic pregnancy. This is the implantation of embryo outside the uterus. Now you have to know what is the normal site of implantation. What is the normal site of implantation? Normal site of implantation. The blastocyst implants in the uterus, usually in the posterior wall near the fundus. Okay, normal site of implantation is posterior wall of the uterus, posterior wall of the uterus near the fundus. So this is the normal site. This is the normal site of implantation. So we got the normal site of implantation inside the uterus, usually on the posterior wall near the fundus. So that is the normal site of implantation. And you have to know what is the normal site of fertilization. Normal site of fertilization. That is in the ampulla of the fallopian tube. So this is the fallopian tube. We have drawn one fallopian tube here, another fallopian tube here. This is the ampulla. Okay, so this is the ampulla of the fallopian tube. So it is in the ampulla, this part, ampulla of the fallopian tube, Fallopian tube is also called uterine tube. Uterine tube, fallopian tube is also called oviduct. So we have different name. Uterine tube, you can also call it oviduct. Okay, so we have site of fertilization is here, site of implantation is here, site of fertilization in the ampulla of the fallopian tube, site of implantation inside the uterus, on the posterior wall near the fundus. This is the fundus of the uterus. Fundus. Okay, we got that. So normal site of fertilization. How fertilization occur? We know that fertilization occurs by the union of two gametes. So For fertilization, we need a male gamete and we need one female gamete. Okay. Gamete are the cells, those that produce from the gonads. Okay. What is the male gamete? This is the spermatozoa. What is the female gamete? That is the ovum. These gametes are coming out of the gonads. So, gonad produces the gamete. So, the spermatozoa is coming from which gonad? The male gonad, that is the testis. Ovum is coming from the female gonad, that is this is the male, this is the female gonad, this is the ovary. Okay, we got gonad, we got gamete, then they will unite together, then we'll get fertilization. Okay, so this gamete, spermatozoa and the ovum, they have 23 chromosomes. So two gamete, male and female gamete, have 23 chromosomes plus 23 chromosomes. So 46 chromosome will get in zygote. Okay. What is zygote? Zygote is the product of fertilization. It is the union of the sperm and ovum together that will lead to formation of zygote, and zygote should have 46 chromosomes. Okay, chromosomes. This zygote at formation is one cell. Then it will multiply. Then we'll get multiplication of zygote. We'll get multiplication of zygote. So from zygote, we'll get 2 cell stays. We'll get 4 cell stays due to mitosis. Okay, 4 cell stays. Okay, due to mitosis. Then we'll get 8 cell. Stays. Then we'll get 16 cell stays. So this will be series of mitosis in the zygote. We'll get 16 cell stays. We call it morula. This is the morula. Okay, it will continue to multiply, but it has a zona pellucidum of the ovary. Still, the zona pellucidum is present. On the 5th day, it will be here. So this is the site of fertilization. Here, ampulla, site of fertilization, sperm and ovum, zygote. This is the zygote. Then we have 2 cell stays. Then we have 4 cell stays. Then we'll get cell division. Ultimately, we'll get here 16 cell stays. 16 cell stays. We'll get 16 cell stays. Then on 5th day, we lose the zona pellucida. So zona pellucida will be lost on 5th day. Okay, zona pellucida will disappear on 5th day. Okay, by this time the zygote, the morula will be inside the uterus. Then from the morula, zona pellucida will disappear and we'll have formation of blastocyst. We'll get blastocyst. This blastocyst will be implanted on the inside the uterus on the posterior wall, usually near the fundus. So this happens. So we got that. So zygote formation, cell division continues. Zona pellucida DJ pairs, you have blastocyst formation. This blastocyst will be implanted here. That is the idea. Okay. So this is usual in normal pregnancy, and embryo will be the fetus, then we'll get the baby. Okay, we got the normal. Now in ectopic pregnancy, the blastocyst will not implant here. It may implant in the ampulla of the fallopian tube. It may implant on the isthmus part of the fallopian tube, in the cornu of the fallopian tube, on the fimbriated end of the fallopian tube. It fertilized product may come out, may be implanted in the ovary. Or sometimes fertilized product may go down to the cervix. It may be in the cervix. Okay. Cervix, if it is in the cervix, still it is an ectopic pregnancy, although cervix is a part of the uterus as a whole. Okay. This is the vagina, fornix. Okay. We got that. So it may be on the ovary. Sometimes what happens? It may go in the peritoneal cavity, in the abdomen, from the fallopian tube is spilled there. It may go to be implanted inside the peritoneal cavity, on the intestine, on the greater omentum, maybe in the pouch of Douglas. This is the pouch of Douglas. This part is called pouch of Douglas. Okay. Also called the recto-uterine pouch. Okay. So it may be implanted here. So it may be, we call it intra-abdominal pregnancy. Okay. That is a possibility. Okay. So that is a possibility also. So maybe many places. Ectopic pregnancy sites. So what are the sites of ectopic pregnancy? Sites of ectopic pregnancy. Okay. Most common site is in the fallopian tube. Around 97 to 98% cases in the fallopian tube. Fallopian tube. Fallopian tube, as I mentioned, it is same as the uterine tube, same as the oviduct. Fallopian, the name came from an Italian anatomist. Okay, so 98% ectopic pregnancy site is fallopian tube, mostly in the ampulla. In the ampulla. Ampulla is dilated part of the fallopian tube. Dilated part. Others may be in the isthmus, maybe in the cornu, maybe in the fimbriated end of the fallopian tube. Okay, so this is the most common site. Other site is on the ovary, on the fimbria. Okay, on the pouch of Douglas or recto-uterine pouch. Okay, so it may be an abnormal location, that's why it is called ectopic, not in the normal location. Okay, so it may be heterotopic ectopic pregnancy, sometimes that may happen. Heterotopic ectopic pregnancy. Okay, suppose we have two ovum fertilized by 2 sperm. One is implanted inside the uterus, another one is implanted outside the uterus in the abdomen. We call it heterotopic ectopic pregnancy. That may happen on very, very rare occasion, maybe 1 in 30,000 pregnancies. Even it may be more than that. So heterotopic ectopic pregnancy is very, very rare. Okay, so we got that. We got the sites of ectopic pregnancy. Again, normal site is here. If it is not here, then it is ectopic pregnancy. It may be in the ampulla, maybe in the isthmus, maybe in the corner of the uterus or intramural part of the intramural or intrauterine part of the fallopian tube, maybe in the fimbriated end of the fallopian tube, maybe in the ovary, maybe it may go to the abdominal cavity, maybe in the pouch of Douglas or the rectouterine pouch, maybe on the wall of the intestine on the omentum. Okay, so we got sites of ectopic pregnancy. What is the epidemiology of ectopic pregnancy? Epidemiology. Okay, ectopic pregnancy number is increasing day by day. What is the statistics in 1970? It is quite different from 2010. Okay, so as the year passes, chance of getting ectopic pregnancy is also increasing. Okay, because a lot of fertility drug, a lot of in vitro fertilization, that may be the reason, or sometimes we don't know the exact reason. Okay, so around 2 to 3% pregnancy are ectopic pregnancy, but around 14% maternal mortality. That is related to the ectopic pregnancy. Around 14%, maybe 13% in some books says. Okay, so we got the statistics of the statistics and epidemiology of the ectopic pregnancy. So it is one of the leading cause of maternal mortality even in the United States of America. Okay, we got the statistics. Okay, now we go the etiology of T1 pregnancy. Okay, etiology. Okay, what are the possible etiology and the predisposing factor? We have to find out that abnormal function of the fallopian tube. Okay, due to there are some changes in the epithelium inside the lumen of the fallopian tube. There may be motility, may be disturbed. There may be block in the fallopian tube. There may be scar tissue in the fallopian tube. Abnormal function of the fallopian tube. If it is fertilized here, it should go to the uterus. But if there is any block there, if there is any scar tissue there, or the cells lining the luminal cell are not functioning properly, then, or maybe some secretion here blocking the passage. Okay, so it may not go to the exact site or the desired site of implantation. It may be stopped there. It may be stopped there, maybe outside. It may go outside. So we have to say the abnormal function of the fallopian tube. Okay, then we have the pelvic inflammatory disease, maybe due to chlamydia, or gonorrhea, sexually transmitted infection that may cause infection to the uterus, the fallopian tube. It may be bilateral, it may block the passage, may lead to ectopic pregnancy, may lead to pelvic pain, may lead to even infertility. Okay, so PID may be due to salpingitis. That means just the inflammation of the fallopian tube. It may be a part of PID, okay, or any other cause of inflammation of the fallopian tube. Okay, we got that. Then history of IUD or IUCD. Okay, IUD or IUCD, we can also say it IUD, that is intrauterine contraceptive device. So in the uterus, sometimes we may use a copper T like that, or we may use the intrauterine contraceptive device. Different type of IUD, maybe shield like metallic substance here. Okay, so that causes inflammation here, and that may prevent the implantation. That is a way of birth control. Okay, so if a patient or the woman is taking IUCD, then there may be inflammatory change here also. So that may change the mucosa inside the fallopian tube, epithelium inside the fallopian tube. That may block the passage of the product of fertilization to go here. Okay, so IUCD. Then we have to say cigarette smoking, cigarette or any tobacco, cigarette smoking. Okay, statistically found that it may increase significantly the tendency to develop ectopic pregnancy. Okay, so we also know that in vitro fertilization, artificial reproductive function, fertilization, that may lead to ectopic pregnancy. Okay, then we have to know previous ectopic pregnancy. Okay, previous ectopic pregnancy. Okay, previous ectopic pregnancy, that may lead to increased tendency to develop ectopic pregnancy. That is the possibility. Okay, or previous pelvic surgery, that may lead to adhesion. Previous pelvic surgery due to any region, maybe in the fallopian tube, maybe in the uterus or any other place in the appendix, so that may cause adhesion. Previous pelvic surgery. So there are many reasons for the ectopic pregnancy. Okay, we got that. So we got the causes of ectopic pregnancy. Causes plus predisposing factor. These are also the predisposing factors. Sometimes we don't know the cause of ectopic pregnancy. That is also possible. It may be idiopathic. Okay, so we got that. The causes of ectopic pregnancy. Okay, significance, yes. Due to ectopic pregnancy, there may be tubal rupture because an embryo cannot grow up here. The tube will be ruptured. Okay, and intra-abdominal hemorrhage, intraperitoneal hemorrhage. Okay, and we have next pregnancy another chance to get ectopic pregnancy after removing this ectopic product. So poor pregnancy outcome and certainly death. So these are the significance, like tubal rupture, intra-abdominal hemorrhage, death, and poor pregnancy outcome. Okay, we got the etiology, we got the significance of ectopic pregnancy. Now we'll go to the signs and symptoms. Okay, as because this is one type of pregnancy, so she will develop the signs symptoms of pregnancy like nausea, vomiting, like that. Maybe in mild form, but certainly she is pregnant, so she will manifest those. We'll get history of amenorrhea. Amenorrhea. Okay, so there will be cessation of menstruation because she is pregnant. We got that. History of amenorrhea. Then there will be vaginal bleeding. Okay, vaginal bleeding may be small amount of bleeding, maybe severe bleeding if ectopic pregnancy is here in the intrauterine part or even the isthmus, more bleeding. If it is on the fimbriated end, then vaginal bleeding may be less. Okay, and certainly abdominal pain, lower abdominal pain, that is a possibility. So there will be intraperitoneal hemorrhage. Okay, so we'll get and features of intraperitoneal hemorrhage. Okay, we got that. So there will be bleeding inside the abdominal cavity, intraperitoneal hemorrhage, and it's because this hemorrhage there will be hypotension, shock. Okay, and certainly there will be pain in the abdomen, severe pain. Okay, initially pain not be very severe, but eventually there will be abdominal, we can say abdominal pain. So it will be initially may not be very mild pain, but eventually it may be very much severe pain. That is also possible, and it is a case of acute abdomen. It needs surgery immediately in most cases or many cases. So we'll get features of acute abdomen that need surgery. Okay, there may be fainting there, is because there is intraperitoneal hemorrhage. What we'll find, we'll all get two signs. One is called Cullen sign. What is Cullen sign? We'll get ecchymosis around the umbilicus. So we'll get ecchymosis around the umbilicus. Okay. We'll get another sign that is called Care sign. May or may not get it. Care sign. What is that? That is irritation of the scapula, especially left scapula. Irritation. Left scapula. Okay, so you get these signs, symptoms of ectopic pregnancy. Then we'll go to the differential diagnosis. Differential diagnosis. Okay, it is a case of acute abdomen, so it may mimic the adnexal torsion. Okay, appendicitis, very common, we may confuse with appendicitis. Adnexal torsion. Okay, what is adnexion? Okay, torsion. adnexia are the structure that are present with the side of the uterus, like the ovary, fallopian tube. These are the adnexia that may be twisted ovarian cyst. Okay, twisted ovarian cyst. That is a possibility. Okay, so adnexal torsion, appendicitis. Even it may be a manifestation of spontaneous threatened abortion. Okay, we may confuse because there is vaginal bleeding. Any vaginal bleeding in a young lady who has no menstruation for 1 or 2 months, okay, then we always, if there is vaginal bleeding, our first suspicion, she is pregnant. It may be a case of abortion, so threatened abortion. Okay, maybe spontaneous threatened abortion. That is one of the differential diagnoses. Okay, it may be a pelvic inflammatory disease, endometriosis. It may look like a PID or endometriosis. What is endometriosis? That means formation of endometrium in sites other than the uterus. Okay, it may be a corpus luteum cyst, hemorrhagic corpus luteum cyst. Okay, it may be a hemorrhagic corpus luteum. Okay, so that these are the differential diagnoses. So we may increase a lot of differential diagnoses like diverticulitis. It might be that. Okay, so we got the differential diagnosis. Then we must do some type of work out so that we can diagnose the case. Okay, what are the workouts or workups to diagnose this case? For diagnosis, first of all, we do the pregnancy test. Okay, then we'll assess the ACG level. It is very important. ACG level assessment. Okay, usually in ectopic pregnancy, the level of ACG is less than that of normal pregnancy. Idea is that placenta cannot expand properly because we are getting ACG from the placenta, from the syncytio-tropoblastic cells. It's because less space, less size of placenta, less amount of syncytio-tropoblast, so there will be less ACG. That is usual. Okay, we got that. We have to do ultrasonography, usually transvaginal ultrasonography. Okay, so by transvaginal ultrasonography, we look any sac is present inside the uterus, anything inside in the adnexia, okay, in the fallopian tube. Okay, we find out that, or any collection in the rectouterine pouch, or what is the condition of the sac. Does it contain any type of cyst, or is there any type of cardiac activity in the developing fetus? Okay, like fetal heartbeat, there may be some cardiac activity found in the 7th week of pregnancy, okay, or maybe in the 6th week of pregnancy. So that may be possible by transvaginal ultrasonography. Okay, so we have to do that test, pregnancy test, AG level assessment, transvaginal ultrasonography. We can also do laparoscopy. Laparoscopy is both for diagnosis and also for treatment. Sometimes some medication is injected to the product of conception in the fallopian tube by laparoscopy. Okay, So to find out that, and then we go to the management. Management should be given by the registered physician or the licensed obstetrician gynecologist, but we have to know what is going on there. So management, we must look for the hemodynamic status. Dynamic, okay, management. We look for hemodynamic status. So we must stable the patient to do something. The patient is hemodynamically stable. He may go through laparoscopic management. If he is unstable, we must manage the patient and we may do the laparotomy. Okay. So it may be laparoscopy. It may be laparotomy. That means to do the surgical opening of the abdomen. Okay, laparotomy. Then, based on the type of damage or the desire for the woman to get pregnant again for fertility, we may do salpingostomy. Or salpingectomy, depending on the situation. But we have some medical management also. Without surgery, medical management is also possible if it is in early stage of pregnancy, ectopic pregnancy, or the size of the embryo is small, less than 3.5 centimeter, and there is no cardiogenic activity, no big blastocyst. So we may manage medically by giving medication. So that is by means of methotrexate. So non-surgical. It should be done only for the early stage of ectopic pregnancy with small product of conception and certainly no cardiogenic activity there. So that is done by methotrexate. Okay, methotrexate, it may be given intramuscularly, it may be put by laparoscopic approach also, it is possible. Okay, methotrexate is actually a chemotherapeutic drug. It will destroy the dividing cell. Our embryo is a dividing bag of cells, so methotrexate works there. Okay, and methotrexate has a lot of adverse effect and also contraindication. If the patient has liver, kidney problem, she should not take the methotrexate. She should not get the methotrexate. So if she has anemia, leukopenia, thrombocytopenia, certainly then it is almost a contraindication to get methotrexate. Okay, and methotrexate may also cause this type of blood dyscrasia like anemia, thrombocytopenia, and also leukopenia. Okay, so the physician will adjust the methotrexate with some other supporting medications. Okay, so once a physician gives methotrexate, then we must go through the series of HCG assessment. Okay, idea is that it should be done on the day 0, day 4, on day 7. Okay, then every week until the HCG is 0. Okay, so when it is 0, then we may find out that methotrexate is working nicely. Okay, so it may be managed medically without surgery or laparotomy or laparoscopy, maybe by laparotomy, maybe by laparoscopy. So it should be decided by the obstetrician and gynecologist. So that's all for today about ectopic pregnancy. If you like my video, please subscribe my channel, support my channel, Share the information with your friends. Have a nice day. Bye now.